please can I now ask for Dr. Pauline Cho to come up and give her presentation.
So I would like to start off with just to say that behind the scene, Minicon has been very active in supporting research, and I'd just like to really thank Minicon because we start working with Minicon. Actually, we start OrthoCare research. Basically, we support a lot of support from Minicon since 2007. So we have a number of collaborative research agreements between PolyU and Minicon. And because there's so many of them, I just select a few for presentation for today. Needless to say, all the studies we conducted, we use the Minicon the Z9 lenses, which is now called Bloom lens. And this is my team, current team members, and particularly Dr. Peggy Zhang, who has been with me over a decade. Well, now, as Dr. Hirakawa introduced us now, our first paper, we reported a longitudinal myopia control effect using OrthoCare was in 2005. This is before Minicon time. And very quickly, I'm not going to go through all this. You can see here that the effect of OrthoCare compared to glasses, and basically, what we also did was at that particular study, we actually also measured VCD, and you can see that even with VCD, there's a lot of concern about how we measure axial length, etc. Excuse me. The VCD actually show exactly the same as result, same myopia effect, control effect. So moving on, we have in 2008, we have this Romeo study, which is the first randomized clinical trial. And that was followed by another study on toric orthokeratology. So with these two studies, we actually use, one was a spherical lens and one is a toric lens. So we can see here that the effect was also very significant. And the result that we got is about 43%. Myopia control, and I'll coming back to the percentage control in a minute. So this is to say we got a little bit higher probably because toric lens actually sits better on the cornea, and we got better concentration. Maybe that gives us better control. So that gives us 56%. So if we look at again just a quick chart with all the different clinical studies that we have. That has been published, I beg your pardon. So you can see that the range of control from 32% to 50-something%, 56% actually. And the randomized clinical trial show about 43%. And of course, we have C et al. And Sun et al. Have done a number of two meta-analysis, and they have shown that myopia control with OrthoCare is about 45%. Of course, there are limitations because raw data are not available and different in methodology. So what we did is that we thought maybe we can combine Romeo and C because basically they are from the same population. And we use exactly the same methodology for these two studies, except that one used toric design and one used spherical design. And combining the two groups, of course, give us a larger samples, which give us added power if we want to. So the two studies use the same experimental methodology. So we published this paper and where we reanalyze the combined data, and we look at the level of myopia control, and we look at the risk of fast progression, and we also look at a new statistic perhaps because I haven't seen that being reported in myopia control before, and that is what we call NNT, and I'll introduce that in a minute. So basically with the combined data, the result gives us again around just below 50%, so 48% there. So when we separate the children or classify the children into different groups based on the rate of myopia progression, so we consider slow as less than 0.18 millimeter, and fast is greater than 0.36, and anything in between as moderate. These are the progression of axial elongation per year. So if we look at the relative risk of fast progression, here we can see that the older children, if the children are older, 9 to 13 years old, less than 13 years old, we have in the control, we have about 13% of the children will have showing fast progression, and the OrthoCare is 5. So relative risk we have is 0.35, but it's not significant. But if we look at the young children, the younger children 6 to less than 9 years old, so 6 to 8, basically. So we can see that in the control group, we've got about 62%. In the ortho-K group, we've got 7%. They give us a relative risk of 0.11 to 1. So younger children with the relative risk of 0.11, that gives us a 0.11 time risk of fast progression during the study compared to control. That suggests that the relative risk reduction is actually 88.8% of fast progression compared to control group subjects. So what is NNT? NNT is a simple measure of the impact of a treatment of a given disease or outcome for a specific or a specific complication. So average number of patients required to be treated to prevent one additional adverse outcomes. So it has limitations, of course. It specifies treatment against what control, how long we're talking about, the duration of the treatment, and also what adverse outcome are being prevented. For example, if a drug has a 1 year NNT of 10, it means that 10 people has to be treated with the drug to prevent one additional bad outcome over a period of 1 year. Okay? So 2-year NNT for this particular study, for the combined analysis, we have younger ortho-K subgroup, age was about 1.8. That means that if we treat 2 younger children with ortho-K, that will prevent one from experiencing rapid progression. So here we're talking about rapid progression over a 2-year period, if we compare that with children wearing single vision glasses. The next one that I want to talk about is a paper that we just published early this year. What we did in this particular studies is that we recruited 91 subjects, children 6 to 15 years old, and with low myopia. And then what we did is we monitored them for phase 1, where they wear single vision glasses for 7 months. And then we shift them to ortho-K for another 7 months. In total, 66 subjects completed the studies, and we have younger children, classify them to younger children, older children, and early adolescents. So 6 to 8, 9 to 12, and 13 to 15. Yeah, so YC, OC, and EA. So if we look at the overall percentage reduction with respect to the history of progression, so basically what we did is we look at how they progress when they are wearing single vision glasses. So you can see here that this is the phase 1. So during the first 7 months, basically, the increase is 0.16, the axial elongation. And when we shift them to ortho-K, the increase was 0.05. And that gives us a percentage of myopia control, if you wish. All subjects considered 68%. Keeping in mind that this is looking at subjects who are the self-control in a sense, okay? Instead of comparing groups. But if we look at different age group, okay, so here you have the phase 1, and the blue here is the phase 2. So for the early adolescent group, the oldest group first, you can see that in the first phase 1, when they're wearing single vision glasses, the increase is only 0.08 millimeter over the 7 months, okay? And then when they wear ortho-K lenses, it's about minus 0.08. Okay. So if you want to consider myopia control in terms of percentage, you get more than 100%. More than 100%. Now, if we consider the older children, you can see in phase 1, when they're wearing single vision glasses, the increase is 0.14, and when they are wearing ortho-K lenses, it's 0.04. That gives us a control of 71%. So if we look at the youngest children, the increase in phase 1 is 0.32. And in phase 2, when they wear ortho-K lenses, it's 0.14. And if you calculate the myopia control, it is 56%. So we can see here that perhaps considering percentage control can be misleading because it depends on how old are the children. And basically, I also want to stress here that for the early adolescent, you can see here that although the percentage of control is very high, But actually, there's no clinical significance in wearing ortho-K lenses because before they wear ortho-K lenses, the progression was so slow anyway, right? So slow there is not clinical significance. I'll come back to that in a minute. So percentage reduction is commonly reported in myopia control studies. We reported that all the time. In the past. The current study, we report that with respect to the history of progression in the same cohort of subjects. All right, so now we know that percentage reduction, if we report that, it is affected by the progression before ortho-K lens wear. All right, it depends on the age of the children as well. So what we did in the studies, we also identified rapid and non-rapid progressors in phase 1. So again, with the rapid, as in the previous paper, we consider them as if they increase more than 0.36 millimeter per year, right? That is 0.21 millimeter in 7 months. The number of subjects with fast progression, when they are wearing single vision glasses, can see here that the red are those who are fast, and the green are those who are not fast. So you can see here that, again, the younger children progress much faster. Most of them are fast progressors, whereas the older children, most of them are not fast progressors. Okay? And this is in line with the paper that we published in 2017, the earlier paper. So if we look at the relative risk and we calculate the NNT, you can see that ortho-K significantly reduced the risk of rapid progression in young children. And the predicted NNT is predicted to protect 1 in 2 subjects, again, in line with our previous study. Although this is a 7-month period only, is again protect 1 in 2 children from rapid axial elongation if we put them in ortho-K. So ortho-K was protective against progression in young children and older children. Percentage of subject, if we look at the YC group, okay, it decreased from 93% to 29%. Obviously, we cannot catch all of them. And in the older children, it's from 25% to 0%. And slow axial elongation during spectacle wear was only observed in older children and early adolescents. It's about 20%. And we are now looking at the data in detail. But basically, what we noticed is that ortho-K showed no significant clinical benefit in reducing axial growth rate. So those who are showing slow progression, they most likely will not benefit from ortho-K lens wear. So we would suggest to monitor older children first to determine axial elongation with spectacle for a period of time, for example, 6 months before considering management. If they are rapid, then we move on to ortho-K. If slow, as I said, our result seems to indicate no or little benefits, but we are looking at it in detail now, and hopefully we have something to share soon. So, excuse me. Yes, there are suggestions that, even low level of myopia can increase the risk of ocular disease, but to be honest, if we ask ourselves, any exposure in life involves a certain degree of risk. I mean, we walk out, we can fall down. I mean, we can fall down the stairs or etc. But are we giving them unnecessary therapy? And I would like to stress on this. Are we replacing one risk with something that is riskier? Because ortho-K do carry risk. So balancing the risk of MK or other ocular complications associated with interventions against those associated with low myopia. This is something that we really need to do. So low-level myopia may be less likely to result in serious complications. Interventions can be expensive, and it also needs a lot of time and effort, commitments from parents for many years. It's not like something we do for a week or 2. So parents may not be able to afford the time or the money, and to suggest that all children, including those with low myopia with slow progression, will create unnecessarily guilt feelings. Right? It will drive patients into debt, maybe, in some places. If more than one child is involved, we do have a situation where parents burst into tears, actually, because she can't afford it for her 3 children, all 3 children. Anyway, So we do have to consider now in modern technology, evidence-based practice, and of course it's not just based on research. It has to take into account clinical expertise, patient's preference, resources, etc. So in conclusion, ortho-K is effective in slowing axil elongation in myopic children, but we have to keep in mind that effect varied among children of different age group. Monitoring myopic children wearing spectacles for a period of time to determine progression rate before considering ortho-K will be prudent. And we did have this sort of, decision 3 or guideline. So if you have myopia, do I have time? Yes? Yes. So if there's no myopia, then you just keep monitoring them. If they have myopia, then we suggest that you consider take into account the age. We'll think if you don't want to, that's fine. If you have no previous record of myopia progression, then we'll suggest monitoring for 6 months first. It doesn't hurt. 6 months, that is not going to create a lot of trouble. And then progression, whether it's slow or moderate or rapid. And if it's rapid, obviously you go straight into recommend ortho-K or any myopia control treatment. If they're slow, then we consider that you monitor them for a few more months, all right? For the, beg your pardon. If they are moderate, for the younger children, we would suggest a shorter monitoring period, okay, because they can start to progress very fast. For the older children, 6 months will be fine. However, excuse me, if for the moderate progression group, of course you can consider ortho-K for children with active lifestyle if you wish to. But we do have to keep in mind all those adverse events that can occur, I mean the complication that can result, and you have to balance the risk, okay? And also we would like to stress that most younger children show rapid progression, and the relative risk of fast progression of myopia in the younger children decreased by 50% at least with the intervention of ortho-K treatment, okay? And with that, I'd like to thank Minikong again, and thank you all for your attention.